Hello, everyone, and a very good morning to you. My name is Dr. Joella, and I am honored to be your host this morning. On behalf of the SGH Department of Obstetrics and Gynecology, I would like to welcome you to our public webinar on ovarian cancer, What You Need to Know. Thank you for spending your lovely Saturday morning with us, and I hope you gain some insights into ovarian cancer. Now, before we begin, here are some housekeeping rules. The video and microphone function has been switched off. You will only be able to see the presentation and the speaker. Should you encounter any technical difficulties, please restart your device and re-log into Zoom webinar again. Please use the Q&A function to post your questions, and we will address them during the webinar or answer them live during the Q&A session at the end. Without further ado, I would like to invite Professor Yong Zitin, Head and Senior Consultant of the Department of ONG SGH, to give the opening address. Prof. Yong, please.
Thank you, Joella, for the introduction. Good morning, ladies, and I assume some gentlemen. It gives me great pleasure to welcome you to our Department of Obstetrics and Gynecology SGH Zoom webinar on ovarian cancer, What You Need to Know. Ovarian cancer is the 5th most commonest cancer among women in Singapore. Any cancer, understandably, is feared, but with the advancement of surgical techniques and treatment, its management is much more patient-friendly, and now there is new hope. However, needing treatment for cancer is not unlike bringing your car that has broken down to a repair shop. So as we move towards healthier SG, we need to think more about how we can make wiser and healthier choices in minimizing our risk. We need to think about, how with our genetics, we cannot change. Chance, we cannot change. But we will always have a choice of how we live, how we eat, whether we exercise, and how we spend our days. So with this, I leave you with our distinguished panel of speakers, Prof. Tay, Dr. Ravi, Dr. Joella Ang, and Ms. Grace Su, to share with you this very important topic. This is a great team in my department who serve not only with their minds, but with their hearts. And so I know you will have a great morning learning. And so I would like to thank you very much again for sharing this morning with us, and to the Patient Liaison Service team for organizing this. So over to you, Joella, to start the ball rolling.
Thank you, Prof. Yong. I would now like to introduce our first speaker, Professor Tay Soon Kwee. Professor Tay is a senior consultant, obstetrician, and gynecologist with special interest in gynecological cancers and tumors. Professor Tay has a career-long research interest and clinical expertise in human papillomavirus infection and women's cancers. He has published more than 110 research papers in peer-reviewed medical and scientific journals. Professor Tay is a faculty member in the academic clinical program for training of residents in gynecology as well as in obstetrics. He is a medical educator and author of 3 books, and has also contributed chapters to many textbooks in gynecology. Here to share with us his vast experience in ovarian cancer screening and prevention. Over to you, Professor Tay, please.
Thank you very much, Joella, and also Professor Yong, for the kind introduction, as well as to put together a program like this morning, so that we can be here sharing some of the important information with the public. My task this morning is to talk on the topic of ovarian cancer screening and prevention. I would like to just share some of the slides with you during this presentation. Right, let me first of all thank you before we start, and let me bring to the front here. Right, I hope that the slide would come out clear on your screen, so that some of the information will be clearer to you. Now, first of all, just as an introduction on the incidence of cancer in Singapore in general, first to show you the changes in the incidence of cancer in men over the last 60 years. You can see that for men, after an initial reduction, the incidence of cancer has remained the same over the last almost 40 years. What about in women? Women always felt that they are more at risk of cancer for some reasons. And let me show you the chart. This orange colored line shows you at the beginning 60 years ago, women actually were much lower in the incidence of cancer compared to men. But as the time progressed over the decades, you can see the incidence in cancer in women actually catch up with the men. Today, indeed, we can say there is equality as far as incidence of cancer is concerned. So yes, this is a concern to you as well as to us as a healthcare provider, because we are seeing more and more women with cancer. But really what I want to do is to talk on ovarian cancer. And this picture shows you this distended abdomen. This woman wasn't here for a cesarean section to have a baby. What she had actually was ovarian tumor, like the picture showed here. And this is a common encounter in my service in SGH, as well as my colleagues who serves publics in other hospitals. It is a common disease. And this morning, I want to focus on 16 facts that I think you may want to know, because these are the common questions I received from my patients. So there are 16 facts. I think they are rather interesting to public and important as well. The first question is ovarian cancer common in Singapore? What do you think how common it is? Right. Overall, among all cancers in women, ovarian cancer accounted for just under 5%. And if you look at people or women who died from cancer, again, just about 5% actually were from ovarian cancer. So 5% is actually considered quite a common disease, because 1 out of 20 would have this type of cancer. But if I draw your attention to young women below 30 years old, ovarian cancer is actually the second most common cancer. So if you hear a friend say someone below 30 years old has a cancer, she is very likely to have an ovarian cancer. So in young women, ovarian cancer is very important. If we look at the more mature women between 30 to 60 years old, ovarian cancer is the fourth most common cancer. So really, ovarian cancer is rather common in Singapore. And this is actually not unique in Singapore. It's the same all over industrialized or so-called economically developed countries. We share the same statistics. The second thing I thought you may want to know is, has ovarian cancer become more common? Just now I show you the chart that the overall cancer incidence is rising in Singapore. Does that apply to ovarian cancer? Are we doing better for ovarian cancer? So here is the chart of what we call age standardized rates of incidence of ovarian cancer in Singapore, again over the last 60 years. I want to draw your attention to this blue line. You can see, yes, over the 50 years or so, it has been climbing up, reaching the cloud. And in the last 5 years, there seems to be a little dip. Obviously, we have to wait and see if this little turning point is something real. Is it going to go down or not? We have yet to see. But what we can understand about this little change in the last 5 years, let's have a look. For Chinese, the proportion of ovarian cancer over the 30 years actually have not changed. It is 4.6%. For Malay friends, they have a slight initial drop from 8.3% to 7.5%. But over the last 10 years, they have stabilized at 7.5%. It is our Indian friends whose ovarian cancer proportions has been steadily decreasing over the 30 years to become from 8.6% down to 5.9%. So this may be a real sort of change in the incidence of ovarian cancer. Not a lot, but I hope this will be the beginning of a new trend in ovarian cancer. And it would really be good news to women. Now, has there been any change in mortality of ovarian cancer? Very often, if you read women's magazine or newspaper, they always say ovarian cancer is one of the most lethal cancers a woman can have. So has there been any change in mortality? Well, again, we have good statistic records in Singapore for 60 years. The red line show you mortality rate from ovarian cancer really has not changed. Yes, we are harping on a lot of new developments in surgical techniques. Yes, we have a lot of new drugs that are available to treat ovarian cancer, but a lot of the time it improves the quality of life for women, which of course is extremely important. But when you come to life or death, it has yet to show the impact for the ovarian cancer. If we look at it more closely, the prognosis, that is the chance of surviving an ovarian cancer, overall is about 45%. That means that more than half will indeed die because of ovarian cancer. And because of that, a large portion of women cancer patients eventually die from ovarian cancer, makes the impression that ovarian cancer is a lethal cancer. And that impression is justifiable. But if we look at the 5 years survival rate for ovarian cancer, it actually varies greatly based on the stage of the cancer at the time of the diagnosis. If a patient has the ovarian cancer diagnosed at stage 1, her chances of survival is more than 90% compared to another patient who has cancer at stage 3 or 4. The chance of surviving 5 years is just around 25%. So really, if we want to make any impact on this mortality from ovarian cancer, it is obvious. You can tell from these statistics that you really need to detect the ovarian cancer early. Only if you can detect it early, you would be able to improve this overall outcome. So my next question is, can ovarian cancer be detected early? How easy can we do it? Now, this chart looks a bit complicated. Let's look at the left-hand side. The 3 color bars are the 3 time periods. The blue one was from 2009 to 2013, and the red bar is from 2014 to 2017, and green bar was for the year 2018, the latest national data available. So this stage 1 cancer, it looks like we are diagnosing more stage 1 in the recent years, which is a very encouraging trend. We are now seeing more stage 1. But indeed, this change has to come from other stages. We see that some of these stage 1 has come from stage 2 patients and a few from the stage 3 patients. But you look at the stage 4 patients over the last 20 years or 10 years, there actually has been no change. We are still seeing many women in the stage 3 and 4. So really, we still need a lot of effort to try to see how we can make the ovarian cancer to be detected as early as possible and not have to designed to this stage that more than 50% of the patients still are actually diagnosed at stage 3 and 4. A lot more effort is needed. So the question is, are there women who are at higher risk of developing ovarian cancer that we must pay attention so that we can help them to have the cancer diagnosed early? And this is what we generally talk about, risk factors for ovarian cancer. And like all cancer, particularly what we call solid cancer, cancer arising from an organ, it is always age dependent. The older we get, the more cancer we see. And as Singapore population generally moving more towards the older populations, we see more cancers overall. So age is always an important factor, and you cannot do anything about age. Genetic factors is responsible for almost 10% of cancers that we see. Most of patients with ovarian cancer do not have a genetic factor. What about postmenopausal hormone therapy? All women have to reach a time of menopause at around 51 years old, and some women would have some symptoms distressing enough that they will need to have some hormonal treatment or supplement, and this is known as postmenopausal hormone therapy. If you use the hormone therapy for 1 year or 2 years, or even up to 5 years, there actually has been no change in your risk of ovarian cancer. Only in a very small group of women who use the hormone therapy continuously for more than 10 years, and then there is a very slight increased risk of ovarian cancer. And so the number of ovarian cancer coming from the group of women who use long-term postmenopausal hormone therapy is actually very, very small. Other risk factors commonly associated with ovarian cancer are women who have difficulty in achieving a pregnancy, they remain no childbirth history, or if they are long-term cigarette smoker. Smoking increases one special type of ovarian cancer known as mucinous cancer. It doesn't actually affect other types of cancer, but it is enough for you to know about this to see whether you think your cigarette smoking habit should be kicked. Now, asbestos is a well-known material. It's a fiber used in industry, and this is well known to be able to cause cancer. Fortunately, asbestos or the use of asbestos is now banned. So you don't actually have much chance to come in contact with asbestos unless you work in a very specific industry. Otherwise, as a general public, you would not be facing these issues. But there are a couple of medical conditions that we know increase a woman's risk of ovarian cancer, and that include endometriosis, insulin-dependent diabetes, and being overweight. So the question is that I wanted to address, because many of you would have these questions: is ovarian cancer an inheritable disease? We look at how genetic factors affect the risk of ovarian cancer in a woman. If you look at a woman with no family history of ovarian cancer at all, her lifetime risk, meaning from now until the extreme old age, the lifetime risk is 1.6%, which is pretty low. But if she shall have one first-degree family member who has an ovarian cancer, her risk would suddenly increase by 3 to 4 folds to become 5%. If the relatives number becomes 2 or more, it went up further to 7%. Of course, if the woman herself has a breast cancer that is known to be BRCA1 or BRCA2 gene positive mutation, then the lifetime risk for her to develop ovarian cancer becomes extremely high. So yes, there are a group of women who are at higher risk because of their genetic background. And this chart just translate what I say verbally into the chart to show you how markedly the risk can increase if a woman is a BRCA gene carrier. Now, I thought I just have a word on endometriosis because it is really very common. It's an inflammatory condition that affects 1 in 6 women. And you can see that and it causes a lot of inflammation. These are the operative picture of the abdomen in the pelvis. You can see these are very inflamed tissues from endometriosis. Endometriosis can also form a cyst known as a chocolate cyst that can be diagnosed on ultrasound scan. But being a very common condition, it is not unusual that you find a woman who has been treated for endometriosis for a number of years and subsequently found to have an ovarian cancer. So if we look at the statistics carefully, this pie chart shows us the red color represents the population of women known to have endometriosis, and the blue color is the population with no endometriosis. And you can see that the cancer incidence in the endometriosis population, yes, increased by a small little wedge here. It really is a very small statistical risk. So I don't think one should worry a lot about endometriosis. It's a very common condition, but only a small number of them would have complications of ovarian cancer. So what can protect a woman? Let's just think about, well, okay, so ovarian cancer is something that is important, but what protects a woman from it? We knew about the risk, but do we know about protective factors? We do know a few things. For example, if a woman has taken what is known as combined contraceptive pills, that is birth control pills. If a woman uses birth control pills for the contraception or for other reasons, such as to regulate her menstrual disorders, she would have lower risk of ovarian cancer. And it is interesting to make a note that the longer a woman is on the pills, the more reduction in the risk of ovarian cancer. So if you take it for a year, you will actually benefit from a lower risk of ovarian cancer. But if you take it for 5 years, your risk is lowered even more. And we have mentioned just now that no children, no childbirth is a known risk factor for ovarian cancer. And the converse is true. If you have children and you breastfeed the children, you actually have much lower risk. To have one childbirth and breastfeeding, you are reducing your lifetime risk of ovarian cancer by 50%. You cut it by half. So it is very important protective factors. Or if a woman, for some reasons, has undergone a hysterectomy to remove the uterus, or she has chosen what is known as sterilization, the tubes, the fallopian tubes being tied off for family planning, or for ovarian tubes, for these fallopian tubes to be removed, then her risk of ovarian cancer are also lower. So we know about the risk factors, we know about the protective factor. What about symptoms? Are they pointers that I have to pay attention to? These are what is known as symptoms, and they include pelvic or abdominal discomfort, increased abdominal size, being bloated, or you have difficulty in eating, you feel full very quickly, or you have to rush to pass urine or bowels. But these symptoms are very vague, and they are not clear in the early stage of cancer. They are more common in the advanced stage of cancer. And also they are usually symptoms of other intestinal disorder as well. So they are not specific to ovarian cancer. And that's why they are very difficult. What about we can screen them? Screening means that you are doing a test in women who have no symptoms. but they want to know if they have an early ovarian cancer. So the test need to be reliable and need to be acceptable. There isn't such an ideal test really. The two common tests that I want to allude is first of all, the CA125, which is a blood test. And it is a known fact that women with ovarian cancer tend to have higher levels of CA125 in their blood compared to women who don't. The problem is that CA125 is also raised for many other reasons. And also in early cancers, almost half of them would not have a raised CA125. So CA125, although it's commonly used as a tool, but it is not a completely reliable test. And many women who test for the CA125 and found a higher level than usual, they would end up undergoing a lot of other tests. Some of them may even cause, apart from anxiety, also some harm. They may need to undergo some surgery which are unrelated to ovarian cancer. So CA125 as a screening test is difficult. What about ultrasound scan, which is widely available? Ultrasound scan, particularly what is known as transvaginal ultrasound scan, that is the ultrasound examination, the probe is passed through the vagina for a better visualization of the pelvic structures. And so it may be useful to detect the ovarian cyst, but there is no clear evidence so far that a woman undergoing regular, for example, yearly ultrasound scan, they would end up to have an earlier detection of ovarian cancer and save them from the life. So individually, they are not ideal as a screening tool. What about when we combine the two using CA125, which is a blood test, and ultrasound scan? I want to highlight, and you don't have to know in detail, but I just want to share with you that there have been lots of studies. For example, this particular study from America, looking at a large group of women, almost 80,000 women, and divided into two groups. One group just ordinary day-to-day sort of taking care of, and the second group went on to have combined CA125 testing and ultrasound scan. And what is the outcome? Ovarian cancer diagnosis, you do pick up more ovarian cancer in the screened women compared to the unscreened. But if you look at the stage 3 and 4, and that is what we are interested in, you remember that we know that you can improve the outcome only if you don't diagnose stage 3 or 4. But you can see that for stage 3 and 4, there is no difference whether you come from a screened population or unscreened population. Most importantly, ultimately, is whether you live. So mortality, you look at over mortality, dying from the ovarian cancer, it was 3.1 per 10,000 in the screened population, and it was 2.6 in the unscreened population. If you look at the number, literally, you would say, wow, if you undergo screening, you are more likely to die from ovarian cancer. Obviously, this is just statistical sort of variation. The conclusion is that there is no difference in the outcomes for ovarian cancer screening. There is no real advantage of combining blood testing for CA125 and ultrasound scan as a screening. We look at the second one, which was even a bigger study in UK, looking at 200,000 women over a period of 16 years. So they have been following this group of women, and they look at the one group that has no screening, and the other group, they either do CA125 or ultrasound scan or both at the same time. And I want to draw to you the conclusion of the study, that is ultrasound tests couldn't find ovarian cancer earlier or save lives. CA125 did detect a little bit more cancer earlier, but it did not lead to less mortality. So the two very large studies show us that screening is not really useful. So where are we now? Should I go for screening after you heard my presentation this morning? And so that ovarian cancer can actually have an earlier diagnosis. We do know, looking at your background history, if you come from a family history that is at low risk or at most average risk, just like anyone on the street, the recommendation is you don't need to go for yearly blood testing or ultrasound scan, just as a form of ovarian cancer. So who should do it? Who should go for ovarian cancer screening? We think that women with a high-risk family history should go for it. For example, if there is a family history of at least more than one member with breast or ovarian cancer, then you should go for screening. Or you have a family history of family members with different types of cancers, but many of them have cancers, we still think that you may have a higher risk of cancer, including ovarian cancer, and you should consider doing it. In fact, in this group of women, we would suggest that they should go for genetic counseling to meet our specialists who would actually consider whether you would go for the testing for BRCA genes or a group of other genes that are responsible for ovarian cancer. So if any one of you comes from this type of the family history, genetic counseling would be a very appropriate approach to define what else you should do. So what can I do if I am a BRCA gene carrier? Is there anything I can do? You know that being a gene carrier, you are the one who has inherited the genes from your parent. And the gene is found in all the cells in your body, not just in the ovary, in all the cells. And currently, up till now, there is no treatment for genetic defects. If there's a defective gene that it has been inherited, that's it. You have to live with that genes. So what does that mean? So why should I know it? We know it, if we want to know it, because there is this thing known as the risk-reducing salpingo-oophorectomy. We know BRCA1, BRCA2, or the other group of genes I highlighted earlier increase the risk of ovarian cancer. So if we remove your ovaries and fallopian tubes, you would have no more ovaries for cancer to arise. So we see that the surgery, salpingo-oophorectomy, that is to remove the fallopian tubes and ovaries, reduce the risk of ovarian cancer with BRCA mutations by 80%. And we usually do it in women after 45 years old. By that time, majority of women who want to have a child or to have children would have done it. And also, by this age, you are closer to natural menopause. So by doing the surgery, we are bringing forward the menopause only by a short time. So that should have a less impact on you. If you should have the surgery done earlier than 45 years old, we do have some concern because early menopause, say you have the menopause at 35 or 40 years old, we know that in long term, this early menopause increase the risk of cardiovascular diseases, osteoporosis, that kind of things. Although, yes, we still can circumvent some of these problems with estrogen replacement carefully. So we tend not to do it for young women, but for a subgroup, we may do it. And you need to see a specialist to have a very careful consideration. So my take-home message for all of you is that screening and preventing ovarian cancer actually included a couple of important aspects. The first one is lifestyle choices. Try to have a baby or more if you can, if a situation allows you. And if you need to use contraception for any period of time, consider if the combined pills is appropriate for you, because the use of it can reduce ovarian cancer. If you are a cigarette smoker, my recommendation is that you should stop it. And one other thing that is within our power is to try to avoid obesity. So yes, some lifestyle modification will reduce your risk of ovarian cancer. Otherwise, look at your family history. If you are at high risk, then you should consider regular ovarian cancer screening, combining blood testing for CA125 and transvaginal ultrasound scan. If you are indeed a carrier of BRCA gene, or one of the genes I highlighted, you should consider at the right time to undergo risk reduction surgery. So we do have all these things within our power. So I hope that by sharing this information, I've empowered you to know what you should do for yourself or your family members, that we can try to prevent ovarian cancer and also reduce ovarian cancer morbidity and mortality. Thank you very much for your attention.
Thank you, Prof. Tay, for that insightful talk. I'm sure our audience has learned so much about ovarian cancer. Now, I would like to introduce our next speaker, Dr. Ravichandran Nadaraja. Dr. Ravi is a senior consultant obstetrician and gynecologist. He was awarded the Sing Health HNDP Scholarship for Advanced Laparoscopic and Robotic Surgery in Gynecologic Oncology at Hanyang University Hospital and Severance Hospital, Yonsei University in South Korea. In addition, he has also completed his fellowship training in cytoreductive surgery for advanced ovarian cancer, pseudomyxoma peritoniae, and hyperthermic intraperitoneal chemotherapy, HIPEC, at National Cancer Center, Korea. He is here today to share with us about ovarian cancer treatment and surgery. Over to you, Dr. Ravi, please. While we are waiting for Dr. Ravi, I'd like to encourage you to post your questions on the Q&A section of the Zoom webinar. Some of these questions will be addressed in the final Q&A session at the end of the talk today.
Hello.
Hi, Dr. Ravi. We can hear you. We can start. Thank you.
Okay, Ken. Thanks, Joella, for your kind introduction. Sorry for some delay, the delay in this sharing the slides. Okay. Today I'm going to talk about is overview on ovarian cancer treatment and the surgery. Before I talk more detail on the cancer treatment and the surgery, it's good to know the anatomical location of these reproductive organs and also the function of these reproductive organs. So if you look at it, the female gynecology organs or the reproductive organ is located in the pelvis. Okay, so these organs is if you look at it, is the front of this organ is a bladder and the behind is a bowel. Another important structures is very close to this organ is what we call as ureter. Ureter is connected between the bladder and the kidney. Okay, what is the function of these reproductive organs? So ovary produce two important hormones, that is estrogen and progesterone. So the estrogen hormones, it is important for females, basically maintain the general health of the women, and also important for the heart and important for the bones. Okay, so if you, let's say you have a lack of estrogen hormones in yourself, or let's say the ovaries stop functioning, there is you may end up may develop menopausal symptoms like you may experience hot flushes, you may have a problem in a difficulty in concentration, sometimes difficulty in sleeping. Sometimes in the worst scenario, you may have and develop depressions. Okay, and also if you, let's say, the lack of these hormones also put you in a risk of the heart problem, especially the higher risk of heart attacks. And sometimes another condition, what we call is osteoporosis, make you easier the bone can get fractured. And the other hormone is the progesterone. This hormone is basically stabilize the lining of the womb. Okay, this hormone is important also for the preparation of pregnancy, where help in terms of growing baby inside the womb. Okay, another important function of this ovary is to produce eggs. Okay, eggs is important, as you know. Without the eggs, the baby cannot form. And what is the function of this fallopian tube? Is this tube is a transport media where the eggs from the ovary travel to the womb. Okay. So basically, this is my next slide is show on the overview and the statistic in Singapore. So ovarian cancer is ranked as a 5th most common cancer in a female. And for gynecological cancer, it is ranked as the 2nd most common. The most common still is the womb cancer, that's a uterine cancer. And most of the women will diagnose at the age of 63. And as Prof. Tay mentioned earlier in his lectures, most of the women present to us at either stage 3 or stage 4. And why? Because for 2 reasons. One, there is no effective screening at the moment. And if you look at it for gynecological organ, cervical cancer can be screened by pap smear and a human papillomavirus. Mammogram used for the screening for breast cancer, colon cancer, we do endoscopy. But unfortunately for ovarian cancer, as shown from previous slides, no reliable test, even the blood test or ultrasound, shown to be effective in terms of detecting early stage of cancer. And the second reason is the symptoms. And a lot of times when you, all these symptoms are not specific, and it is also may not related to the ovary alone. So sometimes, let's say you may experience some symptoms like changes in the bowel habit or urinary problem, or sometimes you have a pain or discomfort. It may be related to the other organs. But let's say you experience these symptoms very often, do see your doctor and get it advice from him what's happening to yourself. Okay. Okay, how we stage the ovarian cancer is we stage from stage 1, 2, 3, and 4. So ovarian cancer consists of a origin from 3 types of organs. One is from the ovary. The second also from either from the fallopian tube or from the peritoneal lining, what we call as a primary carcinomatous peritoni. So if let's say the cancer confined to the ovary or the fallopian tube, this will stage as stage 1. Stage 2 cancer, where the cancer spread from the ovary to the fallopian tube, or from the tube to the ovary, or to the womb or the surrounding structures here, what we call as a peritoneum, or very close to the bowel area. This will be staged as stage 2. Stage 3 means where the cancer cells spread to the abdomen organs. That means it's where the cancers travel from the lymph nodes either in lymph nodes in the pelvis, or in the abdomen area, or sometimes in the lining of the tummy part, or sometimes what we call is if you involve the omentum or the line near the surface area of the liver. So stage 4, where the cancer spread to the like a liver, spleen, or brain, or the lung, or the bone. So if you, let's say, are suspected or confirmed ovarian cancer, we'll do a certain blood test for you. There is the marker, what we call as a cancer marker, CA125, CEA, CA99, and in some group of the women, we do blood tests like a HCG, alpha fetoprotein, or LDH. CA125, this or CA, all this a cancer marker we use as a baseline. So it's also useful to monitor the women after the treatment. Let's say you have a surgery or you have the chemo, then we use this marker how you respond of the cancer to the treatment. At the same time, also we use this cancer marker as a surveillance. That means you come for a regular follow-up, we will do this blood test for you, and based on this blood test, we'll find out whether the cancer has come back or under remission. There's a certain blood test like a liver function, kidney function we do in some women who are going for the treatment, especially like a surgery or chemotherapy. So other relevant investigation, most of the time we do CT scan first. Let's say you are suspected ovarian cancer. So what we do a CT scan, which is include your chest, the chest part, abdomen, the tummy, and the pelvis. This is to find out whether the cancer is confined to the pelvis or whether the cancer spread to the other part of the abdomen or the chest part. And CT thorax is used as a first line. This is because this will help us to guide you in terms of what treatment is suitable for you based on your the cancer. Sometimes we do we'll do MRI pelvis in a certain group of the women. If we suspect there is involvement of the cancer to the bowel or bladder, where such an organ need to remove for the to clear the cancer cells. So it is mainly for operative planning as well as a counsel you of the extent of the surgery and what you're supposed to expect after the surgery. Routinely, we don't do PET scan or the MRI. PET scan in the selective woman we do if you, let's say, to find out the extent of the spread, and sometimes also to differentiate whether this lump or some of the tumors appear like a benign or cancerous. Let's say, for example, we do the CT scan, we found that you have a enlarged lymph nodes in the chest, and then these lymph nodes may be enlarged, may be related to the cancer. So PET scan helps us to differentiate whether these lymph nodes is due to the cancer or not cancer related. And we do a scope. Okay, the OGD basically is a scope in the stomach lining. So let's say the CT scan or you have a significant symptoms which is suggestive of there is something wrong with the bowel, or you may have a stomach cancer. So we will advise you to the scope to make sure your scope is clean. So sometimes what happens is if you, let's say, you have a stomach cancer, so the stomach cancer may spread to the ovary, then the treatment is totally different from what we propose for the ovarian cancer treatment. And the same thing for the colonoscope. If you, let's say, we do a scope for the bowel to make sure your bowel are normal before we will advise you on the treatments, because sometimes if you, let's say, the cancer from the bowel spread to the ovary, as I mentioned earlier, the treatment may be different. Or sometimes if you, let's say, cancer spread to the ovary and to the bowel, we may advise you on the removal of the bowel. Okay, what is the standard of care for the patient with the diagnosis of the confirmed ovarian cancer? The standard of care is a surgery and the chemotherapy. So what is always patient asks us, what is the treatment is suitable for them, and how we decide on the treatment, that is which treatment is suitable for them. So first we have to look at it, the CT scan, and we will find out the extent of the spread. If you, let's say, the cancer spread to the other parts, like say like a tummy, and then we will look at it whether it potentially can remove these cancer cells safely or not. And surgery is very important, because at the end of the surgery, we have to remove the cancer cell as much as possible, make sure there is no cancer towards the end of the surgery. And the second thing is we have to find out, by removing such a cancer cells, whether you can tolerate the side effects or the complication of this surgery, and whether you can recover from any complications. So if you, let's say, you're medically not fit, or let's say you have a blood clots, or you have other medical condition, making this surgery is more complicated to you, maybe we offer different form of treatment, which is I will discuss later. So in general, let's say if the cancer is confined to the pelvis, what surgery we will offer, we will do is we'll remove your both ovary, both fallopian tubes, the womb, the cervix, and the omentum. Omentum is basically the fat layer covering the bowel. So in general, this fat will be affected with the cancer cell first, because this omentum try to protect or prevent the cancer cell from spread to other places. And in certain type of cancer, we do remove the lymph nodes. So if you, let's say you have advanced or the cancer spread beyond the pelvis to the tummy area, which is required to remove the cancer behind the liver or the spleen or the lining of the peritoneum, this may need an extensive surgery. And this may include removal of the lining, and also may part of the spleen have to remove, or sometimes the removal for the bowel. In those younger women, let's say you are less than 30 years old and if the cancer is confined to the ovary or the fallopian tube, so what we'll recommend is that we'll remove the affected ovary and the tube plus the omentum and or the lymph nodes. So the purpose of this fertility sparing surgery is to help you to get pregnant and also to maintain the ovarian function. So what you expect after your surgery? So most of the time, let's say you have a very extensive surgery. So most of the time, what we do is monitor you in a high dependency unit. Sometimes you may have to be monitored in the ICU to make sure you recover well before you go back home. So you may have a tube and a drain after the surgery. The tube and the drain is basically to deliver the fluids and make sure you're well hydrated, and this is how you look at it. We have to make sure your urine all is at you have a normal urine output, and also at the same time, if there is excessive fluids in your tummy, we have to put it a drain to remove all these fluids from your tummy. And pain, a lot of women do worried or scared about the pain. So because sometimes the incision can be in the center part of the tummy, they may experience a pain. So we'll prescribe you a very good painkiller in terms of the oral painkiller and injection form of painkiller or intravenous painkiller. So pain control is very important because your pain is under control. So we want you to move around. The faster you move around, is very good, because this is help in terms of your bowel movement and also prevent the blood clots in the legs as well as the lung. And also shown that is if you start walking around, the earlier you're walking around, then chances of you recover from this major surgery is faster. And we will let you start the drinking immediately after the surgery. And as your bowel movement or you feel better, we will step up of the foods in terms of liquid diets and solid food or the solid foods. And most of the time, if you let's say you have extensive surgery, you may stay in the hospital about 7 to 10 days. And let's say you just had a hysterectomy and the removal of ovary, if you have all the surgery confined to the pelvis, you may stay in the hospital for 3 days. So what we'll do, if you, let's say you're going for surgery, we will refer you to see the anesthetist. The anesthetist will counsel you about all these risks. At the same time, they also find out, is there any risk factors or any condition that you have to optimize before proceeding with the surgery. Let's say you have certain heart conditions. What we'll do is we refer you to see a heart doctor to make sure your heart functions are better, or sometimes in certain cases, make sure you have your diabetes all are well controlled. And bleeding is a major issue. Most of the time we do encounter bleeding, and you may need a blood transfusion during the surgery. There's a few reasons why you have a bleeding. So one is because of the extensive surgery. If you, let's say, tumors spread to beyond the pelvis or involve most of the organs, there is a risk of a bleeding. And also, most of the times, the tumor can be quite vascular. The bleeding can be quite significant. So how we can minimize the bleeding during your surgery or make sure that it's you have require less blood transfusion. One is always inform your doctor when you take any blood thinning medicines like aspirin or the Clexane. So the doctor will advise you when to stop the medicine and when you can resume back this medicine. The second thing, it is try not to take any of the traditional medicine if you can before the proceeding with the major surgery. The third thing is what we'll do, you will monitor your blood count first. If you, let's say, your blood count is on a lower side, we will give you the iron tablets, or sometimes we give you the iron tablets, iron infusion prior to the surgery to make sure your blood count is an optimal level. And the other thing, it is an injury. The injury to the bowel, bladders, or ureters can be happen, but in general, it's on the risk is higher if the tumor is involved with the bowel or the bladder or the ureter. Most of the time, the risk is lower, and we can perform the surgery safely. And the risk of blood clots to the leg or the lung can develop, especially if you're going through a very major surgery and the cancer itself make your blood is thicker. So in general, what we do is we will give you the stocking and a cuff compressor to ensure the blood is pumping very well or circulating properly, and we ask you to let you encourage, or we want you to move around. The faster is the better. Sometimes the physiotherapy will help you in terms of helping you to get out of the bed and so that you can move around. So what is the gynecology effects by performing such a surgery or for the reproductive organs? One is fertility. And about 15% of the women will got cancer at the age of less than 40 years old. So in this group of women, what we'll do is we'll do the MRI and CT scan to make sure the cancer is confined to the ovary. If you, let's say, the cancer is confined to the ovary or fallopian tube, so we'll remove the affected organs, and at the same time we'll look at it under the microscope to make sure this cancer did not spread to any other organs or the lymph nodes. So after the removal, we may refer you to the reproductive medicine specialist. They will talk to you about the egg freezing, and sometimes we will start you on the medicine to stop your menses, like a Leucine or the contraceptive pills to make sure the ovary is quiet during your treatment, especially during the chemotherapy. Another side effects of removing the reproductive organ is the ovarian function. That means once you remove the ovary, there will be a lack of hormones. If you, let's say, your menopause at the age of at the time of diagnosis, you may not experience the menopausal symptoms like hot flashes or the poor concentration or difficulty in sleeping. Let's say you have you still have your ovary still active and you have menses, you may experience the menopausal symptoms like hot flashes or something you're having problem with sleeping, or you may end up with in a worse scenario, you may have a depression. So do inform us if you have all this problem, and then we will try to help you in a way how to overcome these symptoms. So after you had the surgery, what we'll do is we'll look at it, your histology again, and stage the cancer. So most of the time we will have a team meeting at the National Cancer Center to go through all your images, your reports, as well as the stage. So once after we know the final stage, so the following we recommend you on the certain treatment. So let's say your cancer is confined to the ovary or the tube, not show any spread, or the cancer is well behaved, then we will we just monitor you with the regular examinations and the blood tests. Sometimes we may recommend you go for chemotherapy, and in a certain type of the cancers, we may recommend hormonal treatment, and based on the cancer profile, we do recommend a genetic test. So what is the chemotherapy? So basically, chemotherapy is a medication to use to destroy or control the cancer cells. So for gynecologic cancer, most of the treatment used as a combinations. So combinations, the type of chemo we use is a paclitaxel and a carboplatin. And this chemotherapy is shown to be good in terms of improve the survival of the women. And it is given as a intravenous. So what we do is once if you, let's say, you're based on your stage and your cancer, and we think you need the chemotherapy, we'll refer you to see the medical oncologist at National Cancer Center. So the medical oncologist will talk to you about the chemotherapy. So basically you need a 6 cycle of a chemo, and this is the duration of this chemo is about 18 weeks. And this chemotherapy will be given as an outpatient. So before the medical oncologist administer the chemotherapy, they will go through the detailed history about their medical conditions, whether you're fit for chemo or not. Then they will do a blood test like a full blood count, kidney function, liver function to assess whether you're fit for chemo. So another important concept of the ovarian cancer treatment is a neoadjuvant chemotherapy. Sometimes patients do ask me, what is a neoadjuvant and what is the best for them? So basically, neoadjuvant chemotherapy we recommend to the women who have a very extensive cancer cells. And this with the chemotherapy, the intention or the purpose is to shrink the cancer cell, make it cancer cell smaller and less extensive for them. At the same time, it's reduce the complication and because of this surgery. So what is the best? Of course, if you can do the half-front surgery, that is better for you, and it's also is good in terms of improve the survival. Or sometimes neoadjuvant will be even more better in the certain cases where the cancer spread to the stage 4 cancer where it spread to the lung. This group of the women may not benefit with the half-front surgery, and depends on how fit you are. Also, is very important for us. If you, let's say, you are medically fit, you have then upfront surgery is better. Sometimes we do recommend you go for neoadjuvant based on if you, let's say, you have a blood clots in the lung or legs, you have a significant heart disease or the lung problem, that neoadjuvant will be better for you. And the other thing, it is also is preference. Some women prefer chemotherapy first compared to surgery. So basically the duration of this neoadjuvant chemo is 9 weeks. So we give about 3 cycles of neoadjuvant chemotherapy first. And how we know whether you're responding to the chemotherapy is we do a blood test and a CT scan. If you, let's say, your blood test, the cancer marker shows significant response, and CT scan also showed there is most of the tumors responded very well, so we will offer the surgery for you. And after the surgery, you need another additional 3 cycles of chemo that consists about 9 weeks. So what is the side effects of the chemo and how this chemotherapy affects in you? Okay, so chemotherapy will affect the normal cells like a bone marrow. Bone marrow is where this is red blood cell, white cell count, white cell blood, and the platelets produced from bone marrow. And it's also affect the lining like a mouth, throat, stomach, and intestine. So it's affect the peripheral nerve, reproductive system, and air follicles. So let's say when you started this chemotherapy, and if how you know whether the chemotherapy is safe or there is any side effects. Sometimes what we do is we do monitor the your white cell count, your red blood cell, and the platelet count. If you, let's say, you have low white cell count, so there is you had a high risk of infection. So maintain a good hygiene by good hand washings and monitor your temperature regularly. If you, let's say, you develop if you, let's say, you notice you're having high temperature, or you have feel very tired or difficulty in breathing because of a drop in the red blood cell count, or sometimes you then have a bleed easily from the gum or bleeding from the pus when you pass urine or motions. So get a medical advice, and we will advise you and what to do. So nausea and vomiting is also a side effects you can develop because of the chemotherapy. So your medical oncologist most of the time will prescribe you medicine to stop the vomiting as well as nausea. So try to eat frequent amount and small amount of meal, and the liquid diets or the food that you easily digest is better for you. Try to drink plenty of water. This will help to maintain a good hydration. Sometimes your chemotherapy may affect the taste and smells. So do choose the food that is you think is palatable for you, and make sure you eat good protein diets and high calorie diets. And another significant side effects most of the women do experience with the chemotherapies. They feel numbness or tingling sensations, or sometimes they feel they cannot feel the hot or the colds. So during your treatment, if you feel these kind of side effects and it's really affecting you, so what you have to do is inform the medical oncologist, and they will help you to modify the dose of the chemotherapy, or sometimes they may change the chemotherapy. Other than that, they may give you the medication like a gabapentin, or vitamins like a glutamine acid or glutathiones will help to control the symptoms. If let's say after the treatment you still experience these kind of side effects, sometimes what we do is we send it to rehab, then with the physio we may get better, or sometimes we will continue the medication like a gabapentin or duloxetine glutathione medication, or you may consider acupuncture to help you to control these symptoms. So fatigues, I notice most of the women do develop during the chemotherapy. So if you have fatigues, and so most important things what you have to do is make sure you have a good rest. Make sure you go to the bed early and wake up at a time that is regularly. Then try not to exert yourself too much, and make sure you have a good diet and do a regular exercise. So this is my last slide. What we're talking about, what is the important is about the palliative care. So let's say you are not keen on the chemotherapy, or you are not fit for chemotherapy or surgery. We do refer you to the palliative team. This is palliative teams as highly specialized medical care doctors who help you with the control the symptoms and the stress related of your illness. And palliative care is appropriate for any age and at any stage of in a serious illness, and it can be provided along with a curative treatment. Thank you. Hello.
Thanks, Dr. Ravi. That was a very insightful talk, and I'm sure we now know about how ovarian cancer is treated. Our last speaker is Assistant Nurse Clinician Grace Su. In her role as a specialty care nurse in gynecology oncology, Ms. Grace Su works closely with our patients to guide and support them on their cancer journey, along the treatment trajectory, as well as into the survivorship. Her interests includes traveling and astrophotography. She is here today to share with us about overcoming ovarian cancer, a patient and caregiver's journey. Ms. Su, please.
Thank you, Joella, for the kind introduction. Now let me share my screen. So, good morning, everyone. Welcome to today's Zoom webinar on ovarian cancer, what you need to know. I'm Grace, the gynaecology specialty care nurse from Singapore General Hospital, and during today's webinar, I'll be sharing on overcoming ovarian cancer, a patient and caregiver's journey. Just a minute, a technical glitch. Yep. Right, in this picture on the left is Miss Sanin, who is the patient, and on our right is Miss Sander, Sanin's caregiver. Sanin was diagnosed with stage 3C ovarian cancer back in August 2017. Subsequently, she underwent surgery and completed her chemotherapy treatment in January 2018. In the video that we will soon watch, Sanin will also be sharing her surgery journey, her recovery at home, as well as her chemotherapy treatment. In addition, Sanin and Sander will both share on their emotions on knowing the diagnosis before surgery, during hospitalization, discharge home, feelings after Sanin's diagnosis, as well as overcoming stress. Without further ado, let me bring your attention to the video of Sanin and Sander's experience on overcoming ovarian cancer.
Hello everybody, I'm Sanyi, 49 years old. This is my caregiver, Sandra.
Yeah, hello everyone, I'm Sandra. I'm her caregiver.
In 2017, I had abnormal vaginal bleeding, like clots, big clots. Then I make an appointment to see ONG doctor. 1 week before my scheduled appointment to see the doctor, I was admitted because I had fever more than 1 month. I had seen in GP twice. They given antibiotic, but my fever does not go away. Then I went to see staff clinic. They suggested that I admit to investigate the cause of fever, prolonged fever.
There is no reliable screening or diagnostic test for ovarian cancer. That is why it is important to know the signs and symptoms, such as bloating, pelvic or abdominal pain, trouble eating or feeling full quickly, urinary frequency, upset stomach, heartburn or constipation, fatigue, and or menstrual changes.
When I was admitted, they did all the blood tests, then they did a CT scan. So CT scan showed that it was suspicious CA ovary. At the time, I was calm, but honestly saying, I was stressed. I got 8 years boy and 6-year girl, and my husband is not here. I got only helper and 2 kids. Then I went for the pre-op counseling. So the Grace tell me, nurse Grace told me on the time to do deep breathing exercise, early ambulation, then eat high protein diet. After the surgery, I may have drinks, urine tube, then nasogastric tube. So I get ready to have all the consequence.
Upon learning that Sanin had an upcoming surgery, Sanin's husband returned from his work trip to be with her.
When on the night, okay, ready, of course I was not able to sleep. Even I told my husband I could happen anything during the operation also. So even my banker, everything I handed over to him. I was my children, but he encouraged me. He will take care of my children, don't worry anything. He encouraged me, I won't happen anything.
So you're saying that he gave him your bank account so that he can take all your money. You can take it back. You have your bank with you.
That time, she believed him.
Sanin's surgery involves removal of the uterus, bilateral fallopian tubes and ovaries, pelvic lymph nodes, and omentum.
After the surgery, I came back in the late afternoon. I was really drowsy. After the time I woke up, I knew that I have nasogastric tube, urine tube, I got the drip, then morphine pump, then I have cuff compression to prevent the thrombosis, blood clot. So on the next day morning after the surgery, I really was able to sit out of the bed. Followed by physiotherapy came and teach me the technique, how to get up from the bed, and how to do the deep breathing exercise, and how to stretch my legs. On the second day, I stand up and I'm stretching my neck, my hands, I'm doing exercise. My prof came by the time he saw me. Professor came down, she was so happy that I'm doing exercise.
After Sanin's nasogastric tube was removed, she was allowed clear fluids and progressed on to full feeds. By day 3, she was allowed to take soft diet.
I'm using binder, abdominal binder to support my wall. I eat high protein diet, then I still continue doing my exercise, breathing exercise, the ambulation. After operation 6 weeks after, I started chemotherapy.
Sanin began her chemotherapy treatment. It consisted of 6 cycles, with each cycle consisting of 3 sessions given weekly.
After my chemo, my hair started losing, and then whenever I cook, then I try to taste. I also taste as different, no taste like that. But I try to drink soup, and my finger and my toes numbness. I got very long hair, straight hair, long hair. Then I don't want to shock my children, so I cut my hair short fast. So slowly, acceptance by my children, I shave my hair. Then yeah, I want to be beautiful. Then to cover my bowl, I went to the wig shop and I bought a very nice wig. So whenever I go out for the chemotherapy, I wear wig or beneath my stress also. But I try to pray and did meditation. Then during the chemo time, I went down to the park and I did exercise every day. Just physical strength and deep breathing exercise. During my chemo time, my children are very sportive. My daughter always tell me that beauty is not important, life is important. Yes, I am very good, supportive, especially as a foreigner. I was here with the kids and helper. My husband is on and off. He was business there. He was not able to stay with us. But I have very supportive friends here. They always come to me, accompany with me. Even during my hospitalization time, even they give some money and they cook food and send to me. They come and accompany with me. I can share all my feeling with them. Yes, those are, until now they are very supportive too for my family. I got very supportive friends. Always come and take care of me, accompany with me. Whenever I go to chemotherapy, always one of my friends was there to accompany with me. Those are my friends. And I have very good colleagues. My colleagues and my manager also very supportive.
Actually, when I know about her diagnosis, I was so sad for her. Like she's like same age with me. Then she got 2 children. The children also still young, like 8 years, 6 years old. Then her husband also not always here because of he's doing business in Myanmar. That's why just in and out to Singapore only. That's why I feel so sad for her. I just encourage her need to worry about the children, then we can take them and we can take care of them, and just think about the positive way, then just need to eat the high protein diet like that. We got our group, for us it's like our nurses group also have. That's why whoever off, then we go and accompany with her, spend time with her, then we encourage her daily. Always somebody with her. After operation also she stay at home. Then when we got off, then we just cook and just bring for her the food. Then some some appetizer also, we feel like she want to eat this thing, then we just cook for her and just give to her. Chemo day also, the treatment day, we accompany her, brought to the treatment center. Then we accompany her for the day. Then we encourage her. Actually, we have our Myanmar nurses group here also. Then whoever sick, then we just help for them. Whoever off, then we go together. Then we bring food. We give money, whatever. Ampang like that. Then we just give to her, just support because we are foreigner, then our family is not here. That's why we feel for them, then we just help each other.
Never give up. Okay? Accept whatever you have and fight back. Then relax, enjoy your day every day. Enjoy with your loved ones, with your supportive people. Then you can share with your your feeling with your friends, your close, your loved one. So now I can say my completion of the chemotherapy is over 5 years really. I can say I'm the cancer survivor, cancer-free patient. So this is a very, I feel very confident. Yeah. So during these 5 years, I check up yearly. I does not need any treatment. Then regular checkup. So don't miss the checkup. I'm a cancer-free patient now. Yeah.
5 years later, Sanin remains in remission. She uses her capacity as a nurse and her experience as a cancer survivor to help newly diagnosed patients on their journey towards recovery.
We have come to the end of the video. Now let me bring back my PowerPoint slide. So this is pictures of Sanin. On the top in the center was when she was undergoing chemotherapy treatment, and then if we go to the left, she's with her friends, and on the bottom left picture, she's with her colleagues attending a wedding, and with myself, and then with her family. So here are some tips on overcoming ovarian cancer. So firstly, accepting the feelings that you have. So you can be positive and think positively without always feeling cheerful or optimistic. Secondly, surrounding yourself with supportive people. So they can be your close friends and family, a support group, or a counselor. So these people can really help lift your spirits and be there when you need a listening ear. Taking each day as it comes. So set small goals for yourself and build them up slowly. Try to take each day as it comes and not think ahead too much. Good nutrition is also important. Try to deal with hair loss in a positive way if you can. So like in the video that we watched earlier, Sanin shared that, she didn't actually shave bald initially. What she did was cut her hair short first, and then acceptance was gained by her children. And then she subsequently shaved bald. So that is one way to deal with hair loss. And next, not comparing yourself to other women in treatment. Going out with friends to relieve stress, as well as not shying away from sex. Sex can be difficult for many different physical and psychological reasons. When sex is difficult, it's common to withdraw from your partner to avoid sex and in turn avoid intimacy. But this can make the problem worse. So try talking to your partner to explain how you're feeling and what difficulties you are experiencing. Life after ovarian cancer treatment, summarized in A, B, C, D, E, and acronym. So A, for appointments, go for all of your follow-up appointments to monitor for possible signs of recurrence. B, behaviors, adopting healthy behaviors such as not smoking, eating well. C, being cheerful, doing things that make you happy. D, not letting the cancer diagnosis define you. And E, doing the things that you enjoy. So here are some online support resources that are available. We also have a support group event happening on the 18th of September. It is going to be at Labrador Park. So you can scan the QR code to register today. On our right, you can scan the QR code to join the SGH Gynae support group. And with that, I leave you with 2 quotes. You are braver than you believe, stronger than you seem, smarter than you think, and twice as beautiful as you would ever imagine. So not let cancer cause you to sell yourself short or forget your worth. And lastly, you beat cancer by how you live, why you live, and in the manner in which you live. And with that, I come to the end of my presentation. Thank you.
Thank you, Ms. Su, for that wonderful talk. I'm sure we've all learned more about our patient's journey and very useful tips on how we can overcome ovarian cancer. We will now like to address some of the questions in the Q&A. Please feel free to post your questions in the Q&A button. So for our first question, so I've seen a number of people have asked, can removal of the ovaries actually eliminate the risk of ovarian cancer? Perhaps I can get Prof. Tate to answer this question.
Thank you for the questions. I think it's a very important question. Ovaries, we call it ovarian cancer because it involves the ovaries. But the source of the cancer cells could be on the ovaries itself, or it could be in the fallopian tubes next to it, or in the lining of the pelvis and abdomen or omentum we call the peritoneum. So these are the three adjacent structures that can give rise to tumor cells, cancerous cells, known collectively as ovarian cancer. So if we technically remove ovaries alone, yes, we reduce a large chunk of cancer that arises from the ovaries. But we would not be able to eliminate those cancers arising from the fallopian tubes or from the peritoneum. So in essence, in practice, if an ovary needs to be removed, doctors typically will remove both the fallopian tube and the ovary. So we only are left with peritoneum as a potential source of the cancer of this type. And that accounts for less than 15%, 15% of all this type of cancer. So in answers, yes, if you remove the ovaries, you eliminate 85% chances of ovarian cancer, not 100%.
Thank you, Prof. T. Okay, so next question is, can ovarian cysts become cancerous? So I've seen this being asked by a number of patients. Maybe we can get Dr. Ravi to share some of his insights.
Jola, what is your question?
So we have many patients asking that they have certain types of cysts. Can these cysts actually become cancerous?
Okay, a lot of times we do have a referral or women come to see us with a cyst. Okay, what is the common type of the cyst is a physiological cyst. Physiological means you may have an egg cyst or some of the benign cysts. Not all the cysts are cancerous cysts. So what we do is, as mentioned from the beginning, if you listen to Prof. Tate talks, or you look at your history first, whether you have any high risk of developing ovarian cancer based on your history, based on your risk factors. Then after that, next thing is what we do a scans. So most of the times with the scans, they will tell us what is the characteristic of this cyst. If this is the benign cyst or this is abnormal cyst. If you, let's say, the scan showed there is a cyst is benign looking, and so we'll reassure you that is a cyst, this type of cyst is common, so whether you need any close follow-up or whether you have to just discharge you from follow-up. So if you, let's say, abnormal cyst, then we may do additional tests like the CA125. So in general, a lot of times you have cyst means it's not associated with a cancerous cyst. It just can be just a normal cyst.
Thanks, Dr. Ravi. Prof, would you have anything else you'd like to add?
I concur with what has been said. So typically, if it is a physiological, we make first a distinction of a simple cyst versus a complex, a more complicated cyst. A simple cyst, no, it would not go on to become a cancer, even if you leave it for a long term. If it is some other type of cyst, more complicated type of cyst, then we do have a little bit worried. So we would actually consider close monitoring. And this applies to women after menopause as well. I know that there was a question whether a cyst in a postmenopausal years means that it is going to develop into cancer. The short answer is no. So when you see a doctor, they will make a distinction between which type of cyst one is talking about.
Thank you, Prof. So our next question is, I think I saw a question about endometriosis and some of its risk factors. And I think in your talk also you mentioned something about endometriosis and increased risk of cancer. Prof, would you like to take this question?
Yes, endometriosis, as I mentioned, it is an inflammatory condition. And what happened is the cell origins, the origin of the cells arises from the lining of the uterus, we call endometrium. So typically, when we talk about the risk of endometriosis, one refers to the backflow, the retrograde, meaning that the menstrual blood, instead of being totally discharged through the vagina to the external, some of these would follow the fallopian tube and become discharged onto the ovaries and into the peritoneal cavity. And that is considered one potential and important cause of endometriosis. But this is not the entire story. We understood through our research that endometriotic cyst happens because the cells have some damage to their genes in the cells. And so these cells become overactive, not because your hormone is too high. It is actually, there is some abnormality in the genetic makeup of the endometrial cells. And they are under the influence of the estrogen hormones. So every month, the estrogen hormones rises to regulate your periods. It also stimulates these cells on the ovaries and in the peritoneum to grow. And when there is a menstruation, there's a discharge. There is also a slight bleeding from these internal cells, and the blood then cause a lot of inflammation and cause a lot of pain. So endometriosis, there is no just one simple risk factors, but it refers to a particular set of women. So you cannot prevent it unless you are on contraceptive pills that actually regulates your periods, and also because contraceptive pills has some particular hormonal effect in controlling the cell growth.
So I saw that there were a few patients asking where can we go for genetic screening for ovarian cancer. Ms. Grace Su, would you like to answer this question, please?
Thanks, Joella. Yes, so we can go to National Cancer Center for screening, the genetic screening. The other way we can also go is to the polyclinic for referral letter. It's just that the waiting time to see the genetic counselor may be quite long, about 6 months actually. So these are just some of the ways, that we can go for genetic screening.
Thank you, Ms. Su. I saw another question. I think, Prof, you've covered this also in your talk, but I think some of our audience members came after your talk. So how can we reduce the risk of ovarian cancer? And how does self-injectomy reduce the risk of ovarian cancer? Perhaps Prof. T and then Dr. Ravi can address this.
I think I have mentioned earlier that the source of the ovarian cancer cells can come from the ovary, fallopian tubes, or peritoneum. So by taking out the fallopian tubes, known as salpingectomy, you actually remove a source of these cancer cells, particularly the type of cancer cells we call high-grade serous carcinoma, which is one of the commoner ovarian carcinoma, ovarian cancer. So that's why removing fallopian tubes actually would reduce this particular common type of ovarian cancer.
Thank you, Prof. Okay, I think there's still quite a lot of questions. We'll see how much we can cover in the next 5 minutes, and I think we will have to wrap up after that. Okay, I saw there was an anonymous question about stage 3 and 4 ovarian cancer. Why is there surgery still being conducted? What other methods can be used to minimize the pain or suffering of the patient? Dr. Ravi, would you like to take this question?
Okay, a lot of times, right, we do encounter the patient do ask us if you like see you have advanced stage of cancer, why, whether the treatment is necessary, and given that is the survival is not very good, come to the stage 3 or stage 4. So come to the cancers is there's a lot of factors can help in terms of the improve the survival of the patients, and one part is the surgery. So some cancers we do look, if you look at it, if you most of the time, if you let's say you have advanced cancer, we recommend chemotherapy first. And then look at it, this biology, some women do respond very well with the chemotherapy. If you let's say they have a very good response and some part of the cancer cells still persist, then surgery trial will help in terms of remove the remaining part of the cancer cell, because what the other concerns is whether this cancer cell will mutate in future. And other things also, we may have some additional benefit by removing this cancer cell. We have a mobile information how in general this cancer cell respond to the chemotherapy. And before we considering adding more other treatment like targeted therapy or other form of a treatment, like Avastin. So it is good to complete the surgery first before we go ahead with the adding other treatment, because sometimes adding other treatment, they have some side effects and also make it survival may not be good for the patient. So it's good to do a completion of the treatment like a chemo or surgery and the chemotherapy first before we decide on the other treatment and see how's the overall response first. Some of the patients, they may respond very well with the standard of treatment with the chemotherapy and surgery alone. So they may not need like other additional treatment like Avastin or targeted therapy. You have anything to add, Prof?
Maybe I would just for the public interest that when we are dealing with a cancer, we are looking at the potential survivor. You want to survive, you want to win the cancer treatment. There are only 4 things that determines your survival. And one of the important things is the biology of that cancer, how aggressive it is, which you have no say in it. The cancer developed as an aggressive one, it is an aggressive one. And it will come as a stage 3 or stage 4. You have nothing to say. The second thing is how early you have the detection, whether you can detect it in stage 1 or 2. And in this aspect, you do have a little bit of role. If you are at high-risk group, you have the early screening, you might be able to detect it early. So stage of the cancer. The third thing is whether you undergone a good surgery. If you have undergone a good surgery that clears all the tumor from you, wherever the tumor cells were, you have a best chance of survival. The number 4 things is whether these cancer cells responded to chemotherapy of any type, whether the cancer cells responded to it. And your influence is whether you get yourself healthy enough to be able to tolerate the chemotherapy. If you are so weak, you cannot tolerate chemotherapy, even if I have a good drugs, I cannot give it to you. So you do have a role in deciding towards chemotherapy, getting yourself well enough to receive chemotherapy. So these are the 4 things. And among all these 4 things, you can see that the only thing that can actually make a difference to you is the type of surgery. Obviously, your doctors are so experienced, they would judge to see what type of surgery needs to be done. So it doesn't matter whether you're stage 3 or 4. The surgeon would actually look at you to see what is the best surgery. But to have some surgery plays a very important part. That's why, although when I said earlier, stage 4, stage 3 cancer survival in 5 years is 25%. That is overall stage 3 and 4. But not all stage 3 and 4 will die within 5 years. We have plenty of women who are actually very well 5 years, 10 years, 20 years after the treatment for stage 3 and even stage 4 cancer. So don't think that simply because of statistics, you have to give up on a good treatment. And this is the role of a doctor here to tell you which of the stage 4 you belong to. Whether you are going to be one that is in the 25% or you actually have a chance of being one of the others that's going to live the next 20 years. So I think we mustn't let statistics to influence your individual treatment. So there is a difference between statistical knowledge and your individual where your doctor would advise you.
Thanks, Prof. T. There was one question about how does early menopause reduce the risk of ovarian cancer? I saw it being asked a couple of times. Would you like to take that question, Prof?
Yes, menopause by itself, menopause does not influence your risk of ovarian cancer. So if you have the menopause at the age of 40 years old compared to your sister who has the menopause at 51, the risk is going to be very similar. It's other risk factors, like for example, the genetic factors that is going to play an important role.
Okay, I see there are quite a lot of questions. Maybe I'll ask a couple more and then we might have to wrap up and we can take this the rest offline. So there was a question of polycystic ovarian syndrome and its risk of ovarian cancer. Perhaps Dr. Ravi or Prof. T, would one of you like to answer this?
I'd like Dr. Ravi to explain it, please.
Okay, Prof. Basically, polycystic ovarian syndrome itself is not in the risk of ovarian cancer is not increased unless they have other risk factors like as Prof. Theo mentioned earlier in the slides, right? If a patient have a delay, nulliparous, means never given birth before, or they have had the strong family history, this is all make it the risk is higher. But in general, if you have a polycystic ovarian syndrome, the risk of womb cancer is higher if you, let's say, don't have a regular menses. And is there anything you want to add, Prof?
I do. If you are seeing doctors because of polycystic ovarian disease, which typically would give you irregular periods, and doctors would generally prescribe some hormonal pills for you. Most common pills being prescribed is actually contraceptive pills. That's what earlier I say, if you are on contraceptive pills, you remember you actually have a lower risk of ovarian cancer. So polycystic ovarian cancer itself does not increase your risk of ovarian cancer. And by undertaking contraceptive pills as a treatment, you lower your risk further. The only cancer that is related to polycystic ovarian disease is actually uterine cancer, endometrial cancer, which is not ovarian cancer. So that is going to be reduced also by the contraceptive pills. So for a polycystic ovarian disease women, so long as you are under the monitoring of a doctor and you have used contraceptive pills at some stage, I think you do not have to live in fear of increased risk. You have the same risk like any other woman with no polycystic ovarian disease.
Okay, thanks, Prof. There's also, leading up to the question about the contraceptive pills, there are quite a few questions about OC pills and the risk of breast cancer.
Yes. Like they all say, there is no one thing that's good for everything. So ovarian cancer is reduced by the contraceptive pills. You remember I said earlier, the longer you're on the pills, the greater reduction in ovarian cancer. But very few, although the pill is made for women to take it for long term, but many people not taking it for so long. So if you take it for 5 years continuously, from 25 years old to 30 years old, you would have seen a very large reduction in your overall risk for ovarian cancer and uterine cancer. And for 5 years, you would have no change in your breast cancer risk. If you take the contraceptive pills for 5 years or less, there will be no change. If you continue, like some of my patients who like to continue the pills to 10 years or even 20 years, then there is a slight change here. Generally speaking, we view the risk, the background risk for a woman in Singapore to have a breast cancer is around, say, about 13 or 14%. If you don't have a family history, if you don't have a genetic like BRCA or anything like that, just looking at women in general, you have, say, about 14% risk of having a breast cancer by the last day of your life. If you take contraceptive pills for 10 years continuously, then your risk actually will go up from 14% to 15%. So you ask me, is there a difference or not? I say yes, it went up from 14% to 15%. But in reality, does that translate to something significant to you? No. While I increase my number of breast cancer a little bit, but I also have less ovarian cancer, less uterine cancer. So overall, my chance of having a cancer is less if I'm on the pills compared to if I were not on the pills. You mustn't look at just one cancer on its own.
Thank you, Prof. Teh. Thank you, Grace, as well as Dr. Ravi, for sharing your insights as well as your answers to the questions. We have quite a number of questions, but we've come to the end of our Q&A session as well as our webinar. I think what we can do is we can get our audience members to write in through our inquiries. Can I get the slides now, Sylvia, for the closing? So we have now come to the end of our webinar on ovarian cancer, what you need to know. On behalf of the speakers and the SGH Department of Obstetrics and Gynaecology, thank you once again for spending your weekend with us. And we hope that you have gained some insights into ovarian cancer. Please help us improve by giving your feedback. You'll be receiving a link once you exit the Zoom seminar. And there are some slides later we'll be sharing on where you can find us in the ONG Center in SGH Block 5, Level 1. There will also be QR codes in the next few slides that can be scanned to make appointments to see one of our friendly doctors or to send your inquiries through to our website. You can also subscribe to our mailing list to get updated on upcoming webinars. So once again, thank you, and we hope that you have a good day. Goodbye.
Thank you.